Good afternoon, everyone. My name is Sarah Dugan. I'm a mental health pharmacist and faculty at Neomed. Our topic for today's didactic is anxiety and asthma. Our objectives for today are threefold. So first, to identify the prevalence of patients with asthma and anxiety disorders. We'll be looking at all anxiety disorders, so not just panic disorder or generalized anxiety disorder. We're going to describe potential etiologies in common for both asthma and anxiety. Why might this prevalence be occurring in this number of patients? And we're going to list some considerations that may contribute to anxiety symptoms in patients with asthma. We also will briefly look at potential treatment options for these patients, ways to improve both of the conditions. So anxiety and asthma, how much of a problem is this? Anxiety is identified as one of the more common comorbid conditions for patients with asthma. It's been estimated that children and adolescents who have asthma have a prevalence of anxiety up to 30%. So 1 in 3 of the patients may have either a diagnosis of anxiety disorder with their asthma or may be experiencing pretty significant anxiety symptoms. Adults, it also remains in about that 1/3 category, with estimates being about 34%. Comorbid anxiety does suggest patients who have either an identified diagnosed anxiety disorder or just anxiety symptoms have been reported to have altered symptom experiences of their asthma. Asthma seems to be a strong predictor of breathlessness being one of the symptoms of asthma, and it tends to be a relatively strong predictor, moderate to strong correlations with breathlessness in patients with anxiety. And it also occasionally has been associated with diminished lung function. We see a number of different outcomes. This direct relationship between anxiety and diminished lung function wasn't consistently seen in all studies, but it has been suggested, and we'll look at a number of factors for why. So as promised, the why, looking at comorbidity of anxiety disorders in patients with asthma, there have been reports of adverse outcomes. Patients may be experiencing both symptoms as well as adverse effects from treatment a little more significantly. There's been a number of trials that do identify diminished asthma control. So increased symptom exacerbation, increased emergency service use, as well as hospitalizations, patients who require a much more intensive asthma regimen, which is one of the reasons why it has been associated with diminished lung function. So if patients have a lot more symptoms, much more severe disease, require much more intensive treatment, we do see some reduction in their lung function. Is it from the anxiety? Is it because of something else that's going on? It's not a direct correlation. I'm not saying that anxiety is causing this, but it is something that we see in these patients. They tend to have a more significant hindrance in their activities if they have both anxiety and asthma, and they tend to report a lower quality of life than patients who do not have anxiety disorders or anxiety symptoms with their asthma. So it really adds quite a significant burden. These patients also tend to have much higher healthcare costs than what we see with some patients who don't have both comorbid anxiety and asthma. Because I don't want you just to take my word for it. There was a systematic review that was done and published last year. They initially started in looking at tens of thousands of articles, and they narrowed it down. So they had very specific criteria that they wanted to evaluate. The articles had to be available full text. They wanted to be able to see everything, published in English in peer-reviewed journals. The trial design needed to be a case control design. So they wanted to make sure that the comparative groups were an asthma group and a group that did not have asthma. It could be cross-sectional, it could be prospective. They did allow some flexibility there. For the evaluation of anxiety symptoms, patients had to be diagnosed with an anxiety disorder based on the DSM criteria, or it could be self-reported, but it needed to follow the criteria of a well-established measured anxiety measure. So something like the Hamilton Depression Anxiety, or I'm sorry, the Hamilton Anxiety Scale. So different established and recognized anxiety symptom scales to be able to say that, yes, they had anxiety versus just self-report of I'm feeling anxious. They also required that all of the trials that were included had enough data to be able to calculate an effect size. So how much of an impact were they seeing? So from the 19 articles that were included, 10 of them did fall into the criteria where the patients were reporting anxiety symptoms, so they may or may not have had a formal diagnosis. And then 9 of them, they did need to have a formal anxiety disorder diagnosis. They included from these 19 articles, there was over 106,000 patients. And the outcomes they were looking at specifically was the comparison between patients with asthma and those without asthma and the prevalence of anxiety disorder or symptoms of anxiety. What they found was that it was pretty consistent, about 2 times as many. So the odds ratio was 2.08 for those that had an anxiety disorder and 1.89 for those who had symptoms of anxiety. So those patients with asthma were essentially twice as likely than those who did not have asthma to have an anxiety disorder or symptoms of anxiety. This is pretty consistent. There have been a number of other meta-analysis and reviews that have been done. They really see between 20 and 30. Some of them go up to 50%, but those tend to be in a little bit of a skewed population of individuals with asthma who also have anxiety symptoms or diagnosis of anxiety. And that holds true that there's an increased incidence both when the diagnosis occur concurrently. So for example, an adolescent patient with asthma and anxiety disorders, but it also holds true more lifetime prevalence. So when they look at adults who go on to be diagnosed with an anxiety disorder, they're much more likely than the general population to have had asthma. So we see a higher diagnosis rate in those patients even later on if their asthma has been controlled or not controlled, which will be an important factor as we move into the etiology. So common comorbidities that we may see. So why might this happen? What are those links? One of them is implications between asthma control and anxiety symptoms. So if a patient has poorly controlled asthma, they may have a number of different incidents or situations where they're experiencing hypoxia, so low oxygen levels, or hypercapnia, so elevated carbon dioxide levels. This exposure to low oxygen levels and elevated carbon dioxide levels, because there's issues with the gas exchange, may result in some changes and sensitization in the neurons. Specifically, they can see some changes in both the amygdala and the locus coeruleus. So 2 areas that we know are associated with the development of anxiety disorders. So if as a result of the asthma, there are conditions that make those neuronal cells a little bit more sensitive, we may potentially see enhanced sensitivity and anxiety symptoms. How did they look at this? They've looked at this both with imaging, retrospectively in patients who have had asthma and go on to diagnose anxiety symptoms. They've also looked at this preclinically in a number of different animal models where they have been able to replicate incidence of hypoxia has resulted in changes in both of these brain areas, and then they do see different symptoms of anxiety in those animal models. There are a number of other anatomic differences that they've found in patients with asthma. So using PET scans as well as MRI scans, they see changes in connections between the temporal lobe, the parietal lobe, as well as the limbic areas. So some of the messaging, especially related to emotional regulation and overall processing, emotional processing of different stimuli. They've seen increases in inflammation in different areas. The one main area that seems to consistently be identified is the anterior insula. So this is one of the emotion processing areas where they see a lot of turnover and more inflammation than what they would expect, and more inflammation than what they see in a general population. So those who don't have asthma. They also can see a change where the size of different brain structures appears to be related to the anxiety symptoms. In patients who have asthma and are experiencing anxiety symptoms, they've done a couple studies that look at what are the differences that we see in the brain areas. For patients with anxiety, those anxiety symptoms seem to be associated with the size of the pallidum, whereas in controls, patients who don't have asthma, their anxiety symptoms seem to be much more related to the volume of the hippocampus and the amygdala, which is what we would expect. So that suggests that there is different messaging and different pathways that may be being used by patients who have asthma and anxiety versus those who just have an anxiety disorder. Are we able to use this and functionalize this? Not quite yet. But if we can further understand what are the differences, maybe we can drill down and understand the etiology even better. The last area that also seems to be involved is a psychoneuroimmunological pathway. Chronic inflammation has been a hallmark of patients with asthma, especially those who may not be well controlled. Peripheral inflammation may increase cytokine production. We can see increases in interleukin 6, interleukin 10. We see elevated levels of tumor necrosis factor alpha. These cytokines can get into the CNS, and they may stimulate the production of additional pro-inflammatory cytokines by the microglia as well as the astrocytes. By increasing the pro-inflammatory cytokines, it may result in inflammation specifically in the brain, and some of these areas have been related to the development of anxiety disorders. They also have seen some additional markers, so elevated cortisol levels as well as elevated alpha amylase levels in patients with asthma. Both of these elevated levels have been identified in patients who have generalized anxiety disorder. So that may potentially be part of the pathway associated with generalized anxiety disorder. So we can see a number of different chronic inflammatory issues, both when a patient is exposed to a trigger for their asthma, as well as months later. It does appear that a number of these inflammatory markers stick around for a long period of time, not just when they're exposed to that. Overall, patients with asthma may have enhanced corticosteroid production, so we can see elevated levels of some of the corticosteroids in those patients, which has also been associated with the development of anxiety disorders. And in some patients, they've seen that the serotonin transporter expression in different areas of the brain, both in the limbic areas as well as in the brainstem, does seem to be lower. So we're seeing less of the serotonin transporter expression and potentially less of our serotonin signal, or strength of the serotonin signal is possible, which may also contribute to anxiety disorders. So a number of different potential factors that may help explain why we see quite a prevalence between these two conditions. I felt that I would be remiss if I didn't also mention that some of the medications that we could use for the treatment of asthma may also contribute to anxiety disorders. Beta agonists, so both the short-acting and the long-acting, are often a hallmark of treatment of asthma and may result in some anxiety symptoms. So things like albuterol are one of the rescue inhalers that asthma patients may use. It does cause an opening of the airways, but it also may result in a patient feeling some symptoms such as palpitations that may make them anxious. Steroid use, inhaled corticosteroids don't have quite the same amount or prevalence of anxiety as a side effect as much as the oral agents do. But if a patient has poorly controlled asthma, they may be on oral agents and therefore have an increased risk for developing anxiety symptoms as a result of that. And then for some patients who may have an allergic form of asthma, montelukast is occasionally used, which may really help with the asthma symptoms, but may contribute to some mental health symptoms, anxiety being one of them. So not only the disease itself, but the treatment may also contribute to that. But this is a little bit of a complicated story because it could go in both directions. So I wanted to take a look at if this happens together, what should we do for these patients? Is there really a preference that seems to drive how do we improve both of them? There is a little bit of data. That's the good news. The bad news is there's not consensus on which to go after first. So to improve outcomes for patients with anxiety and asthma, this was a trial that was done in patients who had anxiety, a diagnosis of an anxiety disorder. They also could have a diagnosis of depression, and they had to have asthma. The patients were continued in their traditional treatment for 6 months, but they added treatment with an asthma specialist for 6 months. So these patients had moderate to severe asthma. It was not well controlled, and they wanted to see if we capitalize on improving the control of the asthma, what may happen to their other symptoms. So baseline, these are percentages for anxiety symptoms and depressive symptoms. So about a quarter of the patients at baseline had anxiety symptoms. About 12% had pretty significant depression symptoms. At the end of 6 months, so they were following standard of care. Some of them did have dose adjustments, but for the most part, they were just continuing with what their treatment had been. They did see a reduction in anxiety symptoms from 24 to 15%, and from depression symptoms, 12% to 8%. So they saw an improvement even though we weren't really changing treatment of the anxiety or the depression. Now, how about the asthma control? So these patients were relatively poorly controlled at baseline, and they were followed by an asthma specialist. So one of the findings that they had was the average forced expiratory volume in 1 second. So how much air they're able to force out. In asthma patients, if there's a lot of inflammation, we may not be getting those numbers that we want. At baseline, these patients were averaging about 81%. At the end of those 6 months, they had increased to 86%. There was a pretty wide confidence interval around this. So even though it's just a slight increase, there were quite a few patients who had gone up pretty close to being 100%. So most of their symptoms had improved, and they were right where they wanted them to be. So suggesting an improvement in their asthma symptoms. They also looked at the asthma control test. So this was a 5-item scale that is patient administered, and it's looking back over the last 4 weeks. So it scored from 0 to 5, and patients who had less than a 19 were considered to have pretty significant symptoms. So a 5 on the scale is considered very poor control of their asthma. At baseline, these patients were 15. So an average score of 15 to 16, 25 being the maximum. So similar, they were recruited because they had moderate to severe asthma. They did see, even though this was their average score, they saw pretty, that was pretty consistent with the symptoms reported on this score, on this scale. At baseline, so after those 6 months, the average scale on the asthma control test was 19, suggesting that half, if not more of them, were very well controlled now with their asthma. And again, that's consistent with the findings of the FEV1. So they did see asthma scores improved, which we would hope as they were being followed by an asthma specialist, but we also saw some improvement in their anxiety and depression symptoms. So that suggests that maybe by getting better control of the asthma, we're able to improve some of those other symptoms. Now, is that only the way to go? The answer is no. This was another trial that it was a retrospective cohort trial. So they looked back at patients who had a diagnosis of asthma, who also had a diagnosis of generalized anxiety disorder. So they did limit a little bit, or major depressive disorder. Now, these patients had to have been initiated on an antidepressant medication, not an antipsychotic, and consistently have been treated with the antidepressant for 8 weeks. So they wanted them to have started treatment and gotten through that initial period where tolerance may be an issue, and we tend to lose a bunch of patients in terms of continuing therapy. So for 2 months, they had been on an antidepressant. They had both of these conditions, and they then followed them for up to 2 years. What they reported was an odds ratio for the risk of severe asthma exacerbations. Now, these patients also had relatively poorly treated asthma. They had diagnosis of generalized anxiety disorder or major depression. They were on an antidepressant, but the hope was really that they had been optimized. So they did look at if they had optimized their medication and reviewed that. That didn't have as much of an impact. So what they found, sorry about that. What they found was that the odds ratio was about 0.5. So there was a reduction, so a reduced risk for the development of severe asthma exacerbations, as well as for ER visits or hospitalizations in these patients who were on the antidepressants compared to baseline. So they did see an improvement in that. It was true at 12 months, which is what the blue bar is, and then also at 24 months, which is what the red bar was. So we saw an improvement at the 1-year mark in their asthma control, and it held pretty consistent throughout both years. They also did see improvement on their anxiety and their major depressive disorder symptoms. So yes, the anxiety and depression got better because we started an antidepressant, which is good because that's the reason, but they also saw the improvement in asthma. So potentially we could also go after the treatment of the anxiety disorder to improve some of the asthma control. So I guess that doesn't totally clarify which direction you need to go in, and it does give you some flexibility for being able to pursue treatment that's patient dependent. So what is the biggest issue for your patient? So in summary, anxiety disorders and symptoms are very prevalent in patients with asthma, estimated anywhere from 20 to 50%. Most of the reports are about a third of the patients with asthma have an anxiety disorder or significant anxiety symptoms. There does appear to be some common etiology. Hopefully at some point we would be able to get to better understanding what's going on between these, so we have better or more targeted treatment options to be more effective in treating both of these conditions for the patients. And there have been improvements in treatment, both if we start with asthma or if we start with anxiety. And I had pointed out asthma treatments, things like the beta agonists as well as the steroids, they're hallmarks for treatment of anxiety. But as we saw in that one trial, maybe even using them could control some of the asthma and may help make some of those symptoms better. So it likely is going to be more patient dependent. So an interesting situation. Thank you for your time. And I am going to stop my recording.